This is Respiratory Disorders Part 5, and we're going to move down the respiratory tract and discuss issues that are affecting the throat. There are a variety of videos from the Khan Academy that are addressing pharyngitis and tonsillitis. Make sure that you watch those because it really describes for you what the pathophysiology and the anatomy is. And do remember that both of these disorders can be caused by a virus or a bacteria. Repeated tonsillitis can result in a patient being admitted for tonsillectomy and an adenoidectomy, and that is abbreviated T and A. So we're going to briefly go through pharyngitis. Strep is one of the most common causes, as is a virus, and many times it's difficult for us to actually look at a throat and say, it's virus, or yep, for sure it's strep, because they can both have exudate. They both are painful. They both create a fever. They can both create a rash. So you can have the viral exanthem, or you can have strep, what I call strep gone bad, and it's called scarlet fever. So it's a strep pharyngitis that has gone systemic, and the child develops a sandpapery rash all over the skin, and it eventually peels. Another common assessment finding is going to be lymphadenopathy affecting the anterior cervical chain. And then, of course, they can both have nasal discharge. Now, something that most of you have heard of, and many of you may have had as you were a teen, is a pharyngitis that's caused by the Epstein-Barr virus, and we call this mononucleosis. These children can be very ill, and if they cannot swallow and be able to tolerate fluids, we're going to admit them to the hospital and give them IV fluids. So they have erythema and exudate of the posterior pharynx, and that's spelled wrong. There's no G right there. It's supposed to be a Y. They'll have a fever. It can be 102, 103, 104. This is a high fever. They are very, very fatigued. If the liver is involved, these children will become jaundiced, and it isn't the first symptom that occurs. It'll be 1 to 2 days after all of the sore throat and fever began. They may have hepatosplenomegaly, so when you palpate the abdomen, you might actually feel something. Now, different from the strep or viral pharyngitis, mononucleosis produces lymphadenopathy in the anterior and posterior cervical chain. And once they get better, we can still feel the posterior nodes. They become what we call shoddy. They're like little BBs, and shoddy is SHOTTY. You don't have to write it down. I'm just telling you this. They suffer from dehydration because their throats are so swollen and sore they won't swallow anything. Now, this group of kids are going to have a CBC drawn, and we are going to look at the differential. So you'll look at their white count, but in the white count, we look at the differential at, do they have segmented neutrophils, or do they have atypical lymphs? And atypical lymphs are pathognomonic for mononucleosis. We also have another test that we do, and this is a rapid test that's done in a clinic in an ER, or it can be done when we're on the floor, and it's called the monospot test. And it may or may not be positive, even if they have mono. So our nursing interventions related to pharyngitis and mono is to promote fluids. But unlike mononucleosis, we can usually promote fluids orally in someone who has a simple pharyngitis. Both of them are going to require antipyretics. The mono, because their fever is so high, we will alternate Tylenol and Motrin. So we'll give, this is an example, 9 o'clock we give Tylenol, 12 o'clock we give Motrin, 3 o'clock we give Tylenol, 6 o'clock we give Motrin. So about every 3 hours we're giving them an antipyretic. So it keeps the fever down and it also reduces their pain. Provide comfort measures. We try not to do much in the way of anesthetic sprays because then they can't handle their secretions and we worry about aspiration. Viral pharyngitis will not be treated with any type of medication other than antipyretics, but strep pharyngitis calls for a penicillin derivative. So we can give PenVK, which is extremely cheap. It costs about $5 for 10 days of treatment, but you have to administer it every 6 hours for the full 10 days. Other choices would be ampicillin, which is also given every 6 hours, and if the patient is allergic, we're going to go to erythromycin derivatives. Make sure that you assess these kids for a rash. For mono, IV fluids, and then gradually promote oral fluids. Give them a quiet environment so that they can sleep as much as they need to, and do supportive care. Make them very comfortable. Once you know that this child can handle their own secretions and they can do oral fluids, we're preparing them for discharge. If they had hepatosplenomegaly, they cannot participate in contact sports because of the risk of rupturing the spleen. And so this child is going to need a note for physical education program that they can't participate until they're fully cleared by their physician. So make sure that whoever's discharging them provides that note. Tonsillitis also has a sore throat, dysphagia. When you take their vital signs, you would anticipate that they're going to have a fever, and if they have a fever, they're going to have tachycardia. If their tonsils become so large that they can't get any air in, then they're also going to be tachypnic and their O2 sats are going to be decreased. You want to find out from the parents how well are they tolerating fluids. Do they have any allergies? Because we're going to be treating this with antibiotics. And something else that's really important is, are they having difficulty sleeping? Because a child who has recurring tonsillitis ends up having very large tonsils and it can create sleep apnea. As the nurse, you will be taking a throat culture and sending off a CBC, and we frequently will do this in a clinic or in an ER without having the physician or nurse practitioner having seen the child already. We'll have standing orders. The nursing interventions for tonsillitis is administration of antibiotics. If they're treated on an outpatient basis, they'll be oral, but inpatient, it's going to be IV. And they will be getting IV fluids because the reason we admitted them is they're not taking fluids in the way they need to. They also will need antipyretics, and until we can get the first 24 hours of antibiotics on board, we may end up alternating Tylenol and Motrin similarly to when they have mono. Normal saline gargles are helpful for reducing the swelling of the tonsils and adenoids. So if you're working in an ER, your assessment, you should be able to have a general idea of whether or not this kid needs to be admitted or you're going to send them home. So we're going to go through some pictures, and you can see how edematous the uvula and the tonsils are, and within the tonsils there are these little small caves that we call crypts, and there's pus on them. We have a sizing system for tonsillitis, and when a kid has a +3 or a +4, you hear the nurse practitioner or the physician come out and say, oh my God, this kid's got +4 tonsils and the kid won't lay back down. You can pretty well make plans that this child's going to be admitted because they're obstructing their airway. So just stop the video for a minute and take a peek at what these look like. So the 3s and the 4s are the worst ones. Take a look at these. What do you think's going to happen to this kid? Are we going to admit this kid or send him home? You see all the holes that are down on the bottom left? Those are the big crypts. So both of these kids are going to end up needing a tonsillectomy. So here's a child who has chronic tonsillitis and adenoiditis, and the adenoids are behind the tonsils, and it's obstructing his ability to get air in through the nose, and so he is a mouth breather. So if they have a tonsillectomy, this is what their throat is going to look like when you assess it. So you're going to need to have a really good light. If the ophthalmoscope or the otoscope is hanging on the wall, these are great lights for you to use. Otherwise, you need a very bright pen light because you need to assess this child for bleeding. So the black areas is where they cauterized, and there's going to be a white film develop where they actually cut the tissue away. When I was a young child, tonsillectomy was an elective procedure. Two of my sisters and I went in and we had our tonsils yanked, and I don't think I'd ever even had a sore throat because I was only 3 years old. We do it far less frequently than in the past because most kids will grow out of that recurring tonsillitis. The biggest thing that you need to watch for with these kids is bleeding. So what are you on alert for in terms of bleeding? How will you know it's going to happen? If you have a kid who had a tonsillectomy, the last thing they want to do is swallow. So if you notice that a post-op kid is having to constantly swallow, 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 you need to really assess that kid for bleeding. You want to catch the bleeding before they have changes in their vital signs because that's what's going to change next. And if there is bleeding, you need to let the surgeons know. If you have pediatricians on the floor, have them come in and assess the child and anticipate that you're going to be doing what we call serial blood counts. We're going to look at their hemoglobin and hematocrit every several hours and see if it's decreasing. And if it is, this child is going to go back to the OR so that they can cauterize the bleeder. Because of swelling, there is that potential for airway obstruction. So if the child is admitted for this tonsillectomy, we'll put them in a subacute unit so that we can keep our eyes on them a little closer or make sure this child is put close to the nurse's station. For pain management, we're going to give some type of a liquid narcotic. For feeding, we're going to start out with clear liquids and then they can go to full liquids. But what we don't want to do is give red clear liquids because if this child has an emesis and it's all red, is that blood or is it the pink Kool-Aid or the red Kool-Aid that you just gave them? Do not give them any citrus because it will burn like crazy. Typically, they will give antibiotics in the OR just as a prophylactic pre-op, but we don't need antibiotics post-op. These children will go home within 24 hours if we actually admit them, and they will be fully recovered within 2 weeks. They can usually go back to school in a couple of days. So if we do a tonsillectomy on a Thursday or Friday, this kid is back in school on Monday. And this ends the lecture on throat disorders.